we are inviting our next speaker, Professor Dr. M Khodeza Nahar Begum ma'am, for her today's presentation.
About the quality control, and he's also working with our lab since long, like almost 2 years now, that we are trying to improve our quality in our lab, and we are really keen to improve it further to our abilities. And in my tomorrow's talk, I will talk about quality control in grossing of the tissue, the very initial part, how we deal with the tissue, how we should deal with the mastectomy specimen or lumpectomy, and what is the standard procedure for post-neoadjuvant chemotherapy breast specimens. Now today I will just give some illustrations of some of the cases. Only I will show 3 different cases of our breast core biopsies. Is it working? Okay. This is a 72-hour female. Actually, in core biopsies, most of the time we have a mindset that this is nothing but invasive ductal carcinoma. But in real sense, there are certain other entities which we need to keep in mind, that there might be some other cases which might be very difficult to treat with. So we need to be very cautious about making our diagnosis. So here it's a 72-year-old female with a right breast lump. It's a 2 o'clock mass. It was a very little one, only 1.5 by 1.3 centimeter, about 2 centimeters from the areolar margin. So we took the 18 sections showed pretty busy type of fibrotic lesion, which showed some cells would appreciate in between the fibrotic areas, very scattered. And then we went for some of the immunostains. And first of all, we have done ear-pair HER2, which were all negative, and then we went for CQ5-6 which stained very diffusely and strongly, the cytoplasmic stain, and P63 stained the nuclei of the tumor cells. And then Ki67 was not very low and not very high. It was medium. I think it should be about 30% or so. And then the SMA we have done showed how extreme example of desmoplastia is there, and we could see some cytoplasmic and some nuclear stain as well here. So then we went for some other stains, CD10, which stained the nuclei and the cytoplasm both, and then we have stained A1, A3, which was diffused and strong, and S100 also stained some of the cells, and then calponine also was weakly positive. So we had to go through a number of stains here, and then finally we came to the conclusion that this could be a case of myepithelial cell breast carcinoma, and having a differential diagnosis here, like basal-like phenotype. Invasive breast carcinoma is a very, it's difficult to distinguish from immunohistochemistry. As we know, these two entities are, they very much overlap with each other while we do the immunohistochemistry. So we, in these cases, actually, we have to go through some molecular tests. So to come to the accurate diagnosis, if it is very important for the oncologist to know, yes, I think it's important. The exact diagnosis is very much important. So we need molecular tests. So this, there are certain differences. Cell of origin in myopithelial cell carcinoma is the myopithelial cell, and in case of invasive breast carcinoma of basal subtype is luminal progenitor cells. So the origin is just different. And the IFC profile I have shown already, there are some overlappings though. And then in histology, these are mostly of spindle-shaped cells, and in basal type, the cells are pretty, aggressive looking, and there are necrosis and pushing borders, but it's not the case in all the cases. So every case might be different. So molecular test is really necessary to come into conclusion about these type of difficult cases. And then the next case, this next one is
So Dr. Nahar, in previous case, why it is not a metaplastic carcinoma?
Yes, that is also another possibility. Yes, that could be metaplastic carcinoma. I will talk about a metaplastic carcinoma case also, and that you are very correct. That also should come on the differential diagnosis. In metaplastic carcinoma, there are 3 different types of the epithelial cell marker, myopithelial cell marker, and also the mesenchymal marker. All 3 types should be positive. So there was some. There are overlappings in case of metaplastic breast carcinoma. Also, we can think about that in that case also. But we have to go through the molecular test.
Is there any difference of treatment?
That I think that's
myopithelial carcinoma, metaplastic carcinoma, and basal-like ductal carcinoma.
I think
is there any difference?
I think that answer should be given by the oncologist.
I don't think there is difference.
I think that should be given by the oncologist.
But there's a
What
very
should be
different
the
prognosis.
difference?
Yeah.
Very different prognosis.
Different prognosis.
So even though you may be offering chemotherapy to a metaplastic carcinoma, knowing their response rate, etc., so the diagnosis is important for the patient.
Yeah, the prognosis should be a little bit different from each other, I think.
Very different.
So this is a 62-year-old female with a 11 o'clock mass. This was a 2.2 centimeter mass. It was also near the areola. And here you can see the cells are very aggressive looking, very angry looking cells. And also we can appreciate lots of lymphocytes around the tumor cells. So it was so much so that it was very difficult to say whether it is multiple cancer in the same area, a lymphoma and a breast carcinoma together. So you see the lymphoma, the areas of lymphocytic infiltrations are so intense that we had to go for some markers for the lymphoma to see B cells and T cell differentiation, just to see how this looks like under the immunostain CD20 and CD3. So we have seen it's a mixed type of cells are there. So we concluded this is a lymphoid infiltration, maybe lymphoid aggregates next to the cancer cells. And then we concentrated on the cancer cells here, which were so aggressive. And then we, first of all, we have done CK7 and then CK5, 6. So the low molecular weight cytokeratin was strongly positive and high molecular one was not expressed. And then we have done the SMA was very diffuse, and CD34 we have done to exclude Phyllose type of malignant Phyllose tumor, so that was also not expressed. And P63 here was not expressed. So the P63 and SMA both are myopithelial cell markers, but we think that we always should take more than one marker of each case, because one may fail and other may show the space. So it would not be wise to do only one marker of each type. So that's why we always do 2 or 3 different type of markers for the cell of origin to determine the type of malignancy. So here SMA was strongly positive, and then S100 was also not expressed, but vimentin was expressing some of the cells, the marginal, the cellular margins, the membrane positivity it showed. And Ki67 here also not very, I don't know, Ki67 was not very high here. So our ultimate diagnosis was metaplastic breast carcinoma, that because we have found both the epithelial, myopithelial and the mesenchymal markers positive here. So our conclusion was the metaplastic breast carcinoma, and the molecular features really needed for confirming the diagnosis. Yeah. So there may be patent loss or PIK3CA mutations or TP53 mutation, or there may be some genomic alterations. Gene expression profiling is very necessary for these cases. So
why not this case was medullary carcinoma?
Medullary breast carcinoma will not, I don't think it will show mesenchymal marker positivity. So,
Stroma can be positive.
but thus I have to look for the cancer cells, whether they are positive or not. So that's why I don't think it will be a medullary carcinoma. Yes, medullary carcinoma may have a lot of lymphocytes around and things, but even then, the cells are positive for the epithelial markers and very strongly positive to CK7 and also to the mesenchymal and mesothelial markers were also very strong. And now I shall discuss the last case. This is another important case, and it puzzled me so much because it was looking so scary, and there were a lot of cells here and there. It was a 48-year-old female with periareolar mass that was also about 2.5 centimeter greatest dimension. So here you see the cells are a little bit streaming pattern shows. So we went for some stains and CK56. You could see some mosaic type of pattern of staining here. So this SMA also was showed the positivity of diffuse and also the margin of the myopithelial lining is also positive. So this is another stain. P63 also highly distinctly staining the myopithelial lining cells. So we could, looking at all the three stains, and especially the mosaic pattern of CK56, which is very characteristic of the florid epithelial hyperplasia in a case of this particular case of radial sclerosing lesion, we came into conclusion that this is a case of florid epithelial hyperplasia in the background of radial sclerosing lesion. However, we cannot exclude the possibility of underlying DCIS because we know DCIS is quite common in those cases. So we have advised for an excision biopsy as soon as possible to exclude the DCIS. And here also there are some differences, which is quite clear that in IDC, we can call it IDC if we do not go for any further stain. What in the beginning I said that in most of the cases we set our mind that we are dealing with a cancer case. So it's really difficult. Sometimes it's really difficult. What we see, you do not see actually. So this is the case. So myopithelial cell markers are not expressed in case of invasive ductal carcinoma, and cytokeratin expression, low molecular cytokeratin, CK7 should have uniform expression, and genetic alterations are really significant. And so only these three cases I have presented here today, just to for the juniors to keep in mind that yes, there are different types of cancers, various types of cancers, breast cancers present in our country, and we are really, throughout my practice, I have seen so many different types of, breast cancers in our country, and different variability in the genetic expression and in immunohistochemistry expression, and etc. So that's the end of my presentation. Thank you so much.